I'm Martin Lee with Project CBD, and today we'll be speaking with Dr. Bonnie Goldstein. Dr. Goldstein is a pediatrician and a pioneering cannabis clinician. She's the director of Canna Centers, a California-based physician network that focuses on cannabis therapeutics. And Dr. Goldstein is also the author of a highly recommended book, Cannabis. Welcome, Dr. Goldstein.
Morning, Martin. Thanks for having me.
My pleasure. I wanted to talk to you today about an article you co-authored that was recently published in the journal Cannabis and Cannabinoid Research, which is a peer-reviewed publication. Let me start just by reading the title, and then hopefully you can walk us through what the significance of the paper. The title is Cannabis-Responsive Biomarkers, a this is a tough word, Pharmacometabolomics-Based application to evaluate the impact of cannabis or medical cannabis treatment on children with autism spectrum disorder. That's an intimidating title, I think, for someone who's not a doctor or a scientist. So maybe you could sort of explain in a broad sense what the findings are, and what is, for starters, what is metabolomics? What does that mean, and how is it related to cannabis?
Sure. So just the same way that we can draw blood work to measure like white blood cell count or how much sodium you have in your bloodstream, right? We can measure different types of chemicals in the body. And these chemicals reflect the pathways and the changing chemical nature of, kind of how cells are working. So a couple of words that need to be defined. So biomarkers, and this is what we're using, is something called cannabis-responsive biomarkers. These are just chemicals in our body that are part of chemical pathways that help our cells function. Okay, so for instance, one of the biomarkers that we measured is what's called spermine. It's a funny name, but it's called spermine, and it has been associated with inflammation and pain. And it's a chemical that can be picked up in saliva, in blood, and it can be measured. And by establishing, just the same way someone has when you measure white blood cell count in somebody, anytime you get an infection or you get a doctor checkup every year, they check what's called your CBC, your complete blood count. Doctors look at your white blood cell count to make sure your immune system is functioning. It's a reflection of what's going on in your body, right? And so if you were to have a bad bacterial infection, your white blood count would be elevated. That's a tip off to a doctor. Okay, we have to start looking for some serious bacterial infection. If your blood count is low, it may reflect some other pathologic illness. And of course, we have what's called the physiologic range. So your white blood cell count will vary. And normally it's between, for most people, 4,000 and 12,000 cells. And so when we measure it, we can see, are you within normal limits, right? This is what the idea of this is, that you have all kinds of chemicals and cells in your body that can be measured. So, and we can also see, classically, biomarkers are used to look at someone's response to chemotherapy or to cancer treatment. So for instance, or even to reflect the presence of cancer. So in men, a very common test is the PSA, right, the prostate-specific antigen. And you just do a blood test and you can see if that's elevated, oh, that's a tip-off, maybe there's something going on with prostate cancer. And then let's say someone has an elevated PSA, they get diagnosed with prostate cancer and they go through treatment. What do doctors follow to see if their patients are doing well? They follow that PSA. And of course, you want your number to be a certain number, right? You want it to be within that, what we call often within normal limits, or what is really determined to be the normal physiologic range. And so what we did in this study was we took children who are what we call neurotypical or typically developing, and we collected saliva looking for various and specific biomarkers. And we measured hundreds of biomarkers and kind of got it down to about 65 total biomarkers that we could really look at. And then we found about 31 biomarkers that in our group of patients that we measured their biomarkers with autism that actually showed some relevance to the autism and to the cannabis treatment. And we were able to establish this physiologic range for the children who are neurotypical or typically developing, and then we compared the biomarkers in the children with autism with that physiologic range. Meaning, do their biomarkers fall within this? If they fall outside of it, does cannabis treatment correct it back into the physiologic range? And ultimately what we found was that all of the children, it was a very small group, and that's of course one of the limitations. We only had 15 children with autism participate. But we were able to show that with cannabis treatment, their biomarkers trended towards shifting to that physiologic range, which is really fascinating.
Really, I think this kind of data that you compiled from the study sort of buttresses what would otherwise be thought of as anecdotal or subjective accounts of improvement, which are considered generally of lesser value than other types of evidence. But here you have actual data showing, no, it's not just the person saying how they felt. There's some movement in the cells, as you say. So what would be some of the cannabis-related biomarkers specifically? You mentioned spermine. Were there others that were particularly relevant to compare?
Sure. So in the paper, we have 20 to 30 biomarkers that were significantly shifted, okay? But in the paper, we were limited word-wise, so we talked about 3 particular biomarkers. And so one is called N-acetyl aspartate, NAA. And if you look at the scientific literature, there's evidence that NAA is, we know that it's a very prominent neurochemical. It's an amino acid, and it is relevant for multiple reasons in that there's evidence that, in fact, there's a disease where if you don't have it, you basically don't do well. It is, terminal. But you don't have good brain function. You have some dysfunction within the brain. It's involved in neuroinflammation and laying down myelin, which is the coating on the neurons that's very important to neuronal function. And so what we found with NAA was that, and what's interesting, by the way, before I get into the findings, is that from my research on NAA, they talk about it's not good to have too little and it's not good to have too much. You want to have it, balanced is what you want. You don't want a deficiency and you don't want an over. So what's interesting is that in the children that had their NAA measured that was out of whack, whether it was under or over, taking their medical cannabis treatment, an hour and a half later when we remeasured we collected the saliva and remeasured, it shifted more towards the physiologic range. If it was under, it came up, and if it was high, it came down, which is so interesting because that's what we talk about with cannabis, is helping to balance and create homeostasis, right? That shift, not under, not over, but everything leaning towards the middle. So that was kind of interesting. And so, there's studies that show that people with the diagnosis of Asperger's, there's one study that shows that people with Asperger's may have higher levels of NAA, and that other people with autism may have lower. And the only way, by the way, to measure it previously was, remember, it's a neurochemical, was they were using like functional MRI scans and so on, very high technology. This is from spitting into a tube, which is relatively easy to collect for most patients. And it's interesting because that particular neurochemical, again, has been shown to be a abnormality in this specific group in people suffering with autism spectrum disorder. And then I mentioned spermine was one of the other ones that we talked about, and that has to do with inflammation and pain. And I'll share with you that I have a lot of families who have children with nonverbal children with autism who have difficulty communicating, and many of the parents will say their child they must have pain somewhere. The child, it seems uncomfortable. The child is crying or shouting or having a lot of difficulty. And this is very interesting to me, that the spermine was high in many of these patients or very low, and then again shifted towards the physiologic range. And then we looked at another one that we documented, what's called DHEAS, so I want to make sure I say it right, dehydroepiandrosterone, which is a hormone, like a precursor that leads to male and female hormones. And this has been associated with, especially in males, with aggression. And we found this was a cannabis-responsive biomarker as well in our patients.
Well, you say that the dozen neuroatypical patients that were part of this study, once they are administered the cannabis-based medicine, you said whether it's too high or too low in terms of what the biomarker shows, they're coming toward normal in either direction. Was it always the same remedy? I mean, people talk about CBD, of course. That's been a hot thing now because it's not intoxicating, as if that's
right.
wrong.
Well, that's a great question, Martin. And what we did in the study was, and the reason I was involved was because I take care of a lot of children with, epilepsy, autism, and so on. And when Cannabis, who does the technology, approached me, they were looking for children to participate in the study who were already on a regimen of cannabis that seemed to be helping with either the child or the parents saying, as you mentioned earlier, anecdotally, my child is better. My child is doing well. And as we all know, the scientific community doesn't accept this as evidence. Someone saying they feel better is not evidence to the scientific community. We want to see numbers, scans, something that shows better, right? Or improvement. And that it not only that it's there, but that it's statistically significant. That it's not by, and what we mean in the scientific community when we say statistical significance is that it's not some other factor or just random or by chance that we found these results. And so what we did in the group is we recruited ages 6 to 12 with autism who were on a cannabis regimen where they were showing improvement, and at least it had been stable for over a year. Now, we may have made some changes during that year, but the patient was showing ongoing, continued benefits from cannabis medicine based on not only parental reports, but reports from therapists and teachers. And so, and the reason we recruited these patients was because, as you know, it's not one size fits all. I steal that from you. Cannabis medicine is very personalized and customized. And when you very first start out on a cannabis, what I call the cannabis journey, it can take months sometimes to figure out what works best for any particular individual. And what we didn't want was in our population of patients, we did not want to have patients who were switching things up and who were having bad days, and here we are coming in trying to measure something, but they're not showing a response. We wanted to document in these patients that were showing benefits that it correlated physiologically to that there was a correlation between the chemical underpinnings versus and what the parents were telling us, and it's very important to point that out. It can take time. Some of these patients have been on my treatment for, longer than 1 year, 3 years, 5 years, before we really found a nice place. And then you have to remember too, autism is a spectrum disorder. So there is no one size fits all because patients have different symptoms. Some children are very aggressive and some are never aggressive. Some patients are fully verbal and some are nonverbal, completely nonverbal. So that's why it's a very heterogeneous population to study, and it can be difficult to draw conclusions. I just want to point out that what we did was we collected saliva in the morning before they got their morning dose of medical cannabis, and then we collected the saliva again at 90 minutes, around 90 minutes, and that correlates to when the parents said we saw the child responding to the medicine. And by the way, in the paper, table 1, which you'll find like on page 3, it lists the children by age and by and how many doses a day they were taking and what the cannabinoid makeup was. So CBD, THC, CBG, CBN, THCA, and CBDA. And when you look at that chart, they're all over the place because, again, it's personalized to them.
It was just a study, I think, that came out of Israel focusing on autism, and I think the conclusion or the upshot was, well, THC works better than CBD in this situation. Is that, I mean, are we looking for the best cannabinoid here? Or as you say, it's really a combination that's going to work best, and the combination may shift from person to person, even from the time of their life.
Right.
So when you hear of a study like that,
right. Well, and it depends on who you recruit into your study. If you recruit only children who are highly aggressive, I would agree that THC plays a very large role. But if you recruit into your population of patients in your study that half are aggressive and half are not, you're going to find something that may not run through all the patients. I mean, there is some correlation that I use clinically. You know, if somebody comes in and says, my child's tearing up the house and beating us up and highly self-injurious, I lean more towards initiating THC earlier than unless the parents have, some other information or a preference not to use THC, but that would have me lean towards using more THC than not, or at least as part of the mix, right? So I've never been afraid to use THC in my patients, and you have to remember too that there are now a number of studies that document that children with autism have low levels of anandamide, which is a natural endocannabinoid that we make, which I love you call your inner cannabis compound. And when you have low levels of deficiency, you have to remember that for anandamide, CBD is not a direct replacement for anandamide. It can help make the body's own anandamide work better. But for some patients, they need THC because, as we know from Dr. Meshulam and others, THC seems to be the direct replacement for anandamide. And I want to make it clear to anybody listening, my patients are not walking around stoned and incoherent and impaired. They are, and some patients, the parents will call me and say, oh, you know, his eyes are a little, we upped the dose and his eyes are a little red and he seems a little silly right now. We make very tiny changes, so we try to avoid any kind of, making the child uncomfortable or impaired. But I will tell you that many of these patients, because they're deficient in anandamide, they can handle a lot higher doses of THC than most adults. And we also know from a study that it looks like children do not have fully developed cannabinoid receptors, so they may be less sensitive to the effects of THC. And remember, what we're trying to do is kind of feed the brain just that little bit of trigger at that receptor to help send that message of homeostasis.
So you indicated when we talked earlier that you accumulated a lot of data as part of this study, and much of which didn't make it into the paper. So, well, can you give us a hint as what's in store? What's next? Will there be other research papers published based on this work?
So we are planning to publish a second paper based on the same group of patients because we measured so many biomarkers and there were so many interesting and significant results that we couldn't pack it into one paper. So the next paper being published is looking specifically at what we call the lipids, the lipid biomarkers, those that fall into the fatty acid category. And so in looking at that, what's so fascinating about that and what's fascinating about the results is you have to remember that our endocannabinoid system is mostly made up of compounds that are fatty acids. anandamide, and so on. And remember, the compounds from the cannabis plant, the phytocannabinoids that we're using to help feed this system, are also lipophilic fatty acids. And so we want to be able to, well, we're going to publish that data to kind of show that these compounds that are changing in response to the cannabis treatment, not only does it affect other areas of the brain, but also within that endocannabinoid system.
And last question, Dr. Goldstein, is what the implications of this type of research focusing on metabolomics has for cannabis therapeutics in general? Because as far as I know, I don't think there's been a study done on this. And this
right. Yeah. Well, so pharmacometabolomics. Oh, sorry, I lost you there for a minute.
I was just going to say, how applicable would this kind of be for other conditions, not autism?
Right. Well, we're hoping to do a we're hoping to do a study looking at the pharmacometabolomics for those who are using cannabis to treat neuropathy, which is nerve-based pain. So hopefully that is another study that we're doing down the line. But the way to kind of look at pharmacometabolomics is it's a way to look at how your body is responding to a particular intervention, to a treatment. Now, it's interesting because this technology has been used before. Like, for instance, it was used to look at the cholesterol-lowering drug, one particular cholesterol-lowering drug, and how, and it's pretty technical, so I'm just going to kind of glaze over it, how people with certain gut issues, how they metabolize their cholesterol-lowering drug and why they may not fit with that drug. So pharmacometabolomics can look at not only drugs, but also just your own baseline chemistry and your response to drugs. And so kind of cannabis here is the drug we're looking at, right? But really what we're looking at is the chemical response. I foresee this technology potentially to help with optimizing treatment and measuring response. So if I have a patient who is brand new to cannabis and has not been using it, I can get a baseline profile of their biomarkers from saliva. And then 3 months into treatment, I can then collect saliva again and look and see what seems to be beneficial, what's improved. Are there biomarkers that are still off the charts that we should be addressing with certain cannabinoids? Like if we haven't tried CBDA, am I noticing a trend in patients that CBDA helps to imbalance a particular biomarker that reflects, let's say, inflammation? So what we're hoping is to expand this technology, and it's basically just another way to measure. Am I seeing improvement? Now, look, not everybody gets better with cannabis. And one of the things I would love to see is, what are we missing in these patients? Why isn't their body responding? What is happening? Why do only some people respond? And I think this is just a tool rather than me sitting here trying to think of why the patient isn't responding. Here I can have some objective data that I can look at and say, oh, this is interesting. All the children with this biomarker that's off the charts are not responding. Well, that's interesting. What does this biomarker reflect in their chemical pathway? What if they're missing an enzyme? What if they are low on a particular mineral in their body, and we can correct that? I mean, the whole goal of this is to try to achieve more knowledge to be able to help these patients get a response from cannabis, but also other medicines as well.
It's very encouraging. It's really fascinating. Look forward to hearing more about what you're coming up with, and good luck on all of this. Thank you, Dr. Bonnie Goldstein.
Thank you, Martin.